So good evening, everybody. Hope I'm audible to everybody. So now for next 2 hours, we will be seeing about last 2025 NEET super specialty question paper with regards of cardiovascular and thoracic surgery. So this NEET super specialty 2025 proved the importance of CVTS. We have got around 33 questions from cardiovascular and thoracic surgery alone. So in this section, we will discuss about the individual questions and what are the other formats that the questions can be asked and how to deal with this question and how to decode these questions from cardiovascular and thoracic surgery. Coming to the first question, if a patient presents with the murmur after 6 weeks of birth, the most likely diagnosis will be. This question is from Congenital Heart Disease chapter. So, if a patient presents with murmur after 6 weeks of birth, that is the question. Here the answer will be VSD. Why VSD? If one of the option is given as PDA, that is patent ductus arteriosus, this can also be considered as the correct answer. VSD, that is ventricular septal defect, or PDA. Why? Because both VSD and PDA, both VSD, ventricular septal defect, and patent ductus foramen can be present throughout the lifetime. Okay, because it is present since the birth, this will become more symptomatic after 6 to 8 weeks of age because of the pulmonary vascular resistance. Because of the pulmonary vascular resistance that reduces and results in the increased pulmonary blood flow. At birth, during birth, the lung will expand. This will produce an initial drop in pulmonary vascular resistance, following which there will be a continuous drop in pulmonary vascular resistance at the age of 4 to 6 weeks. 4 to 6 weeks, the pulmonary vascular resistance will reduce and reach adult level of pulmonary vascular resistance. So the pulmonary flow will increase. When the pulmonary flow increases, shunting of blood, volume of the blood that is being shunted from the systemic or left heart system or circulation to the right heart circulation will increase. For example, consider this to be the aorta, pulmonary vein, or the pulmonary artery, pulmonary artery. This will be the PDA. When the resistance is high, the flow from the aorta to the pulmonary artery will be low. When the pulmonary vascular resistance is high, flow, that is left to right shunting, will be very low. Okay, this happens even in the VSD. Consider this to be the left heart, this is the right heart, and this is the VSD. Of course, the left heart will have higher pressure than the right heart. Similarly, aortic pressure will be more compared to the pulmonary artery. But until the resistance in the pulmonary circulation is high, the flow from the aorta to the pulmonary circulation will be less. So the left to right shunt volume will be less. And patient may not have any signs or symptoms at this moment. And when the volume of blood flowing through the shunt is less, here will be very soft. When the volume increases due to the fall in the pulmonary vascular resistance, then murmur intensity will also increase. This is the reason why we get increased pulmonary resistance after or between 6 to 8 weeks. Okay, so coming to the next question. The next question is also from the congenital heart disease chapter, Ebstein's anomaly. Which valve is commonly affected in the Ebstein's anomaly? Here, the answer will be tricuspid valve. Okay, the answer will be tricuspid valve. So, you should know something basic about Ebstein's anomaly. Ebstein's anomaly is a congenital defect that affects the tricuspid valve. Tricuspid valve has 3 leaflets. We have 3 leaflets: anterior, posterior, and septal leaflet. In Ebstein's anomaly, the septal leaflet or the posterior leaflet will be displaced downwards into the ventricle. So considering this as the left heart, this is left and this is right. Right atrium and right ventricle, left ventricle. This will be the annulus, and that is atrioventricular junction. Atrioventricular junction, where the normally we will have our atrioventricular valves, like a mitral valve in the left side and tricuspid valve in the right heart. Here in Ebstein's anomaly, consider this to be the anterior leaflet. We will have a posterior leaflet from there, and this will be the septal leaflet. Instead of origin from the annulus, in Ebstein's anomaly, the septal leaflet will be located down below. Of course, the posterior leaflet can also be displaced downwards. So the anterior leaflet will elongate to cope with it. This will give a sail-like movement of anterior leaflet. The most important thing to be noted is that this part is the atrialized ventricle. Atrialized ventricle, or called as pseudo-ventricle. Okay, this is called as atrialized ventricle or pseudo-ventricle. So I'll make it clear again. Consider this to be the right atrium and this to be the right ventricle. Normally, we will have consider this to be the normal aspect. I'm just drawing the right side of the heart, right atrium, right ventricle. This will be the tricuspid valve. Here in Ebstein's anomaly, the valve leaflet will be displaced downwards. So here, this part is the true atrium, and this part will be the atrialized ventricle. and this will be the true right ventricle. So what will happen in this situation? What will happen in this situation? The volume in the right atrium will be more, and the volume in the right ventricle will be less. So the pulmonary blood flow will reduce. The volume in the right ventricle will be low, resulting in the reduced pulmonary circulation. So this is about the basics of Ebstein's anomaly. Of course, the investigation of choice for this will be echo. And there are lots of procedures for operating the Ebstein's anomaly. Commonly, we do Cohn's procedure and Stan's procedure. We are not going deep into the management part, because in management part we have to divide the procedures into biventricular procedure or single ventricular procedure, as a palliative procedure and curative procedures. So for MCQ purpose, just know these two names: Cohn's procedure and Stan's procedure. So this is an image from Bailey. What is the anomaly in this image? Very simple question. This is the right side of the heart. This is the left. This is the SVC, IVC here, pulmonary artery, main pulmonary artery. This is left, and this is the right pulmonary artery, and this is the aorta, right atrium, and right atrium will be towards the right side, and the left atrium will be posteriorly located. Left atrium will be posteriorly located, and this is the right ventricle with the tricuspid valve. Here, this is the pulmonary veins, left atrium, mitral valve, and the left ventricle. You can see the anomaly here. From the right ventricle, aorta arises. From the left ventricle here, pulmonary artery arises. So this is called as transposition of great arteries. This is the great transposition of great arteries. So the anomaly that is mentioned in this diagram is transposition of great arteries. Whether this is compatible for life or incompatible for life. Unless until there is a shunting in transposition of great arteries, systemic circulation and pulmonary circulation will be parallel to each other without any connection or communication. So this is incompatible for life. It is compatible at two situations: when there is a shunting between the systemic circulation and pulmonary circulation, like a large VSD, the large PDA, this. And also we should know about one more entity that is called as CCTGA, that is congenitally corrected transposition of great arteries. What does it mean? What does it mean? Of course, as the name implies, heart itself will correct. Minus plus minus, minus into minus is always positive. In these cases, there will be atrioventricular discordance. Atrioventricular discordance will be there, which means right atrium will open into the left ventricle, and the left atrium will open into the right ventricle. This is CCTGA. Right atrium will open into the left ventricle. From left ventricle to the pulmonary artery. So this is the double negative thing. Congenitally corrected transposition of great arteries. And right ventricle will give rise to aorta. Here we will have an atrioventricular discordance and also ventriculo-arterial discordance. This is congenitally corrected transposition of great arteries. So this question shows the importance of diagrams in Bailey and Love and Sabiston. Candidates must go through the images in the standard prescribed textbook. So about TGA, it is the second most common cyanotic congenital heart disease. We all know about the classification of congenital heart disease as congenital cyanotic and acyanotic heart disease. So this TGA comes under cyanotic congenital heart disease. This usually presents in the newborn, as mentioned earlier, aorta arises from the right ventricle. This is called as ventriculo-arterial discordance. And here the systemic circulation and pulmonary circulation will run in parallel to each other. And this condition is incompatible for life. This condition will be incompatible for life. So to make it compatible for life, God itself will correct these anomalies. That is what we discussed previously about congenitally corrected transposition of great arteries, where there will be atrioventricular discordance along with ventriculo-arterial discordance. So coming to the next question, this is also an image from Bailey, and without these markings. In exams, they are given without the markings. So here, this is the long axis 4-chamber view of echo. This is the left ventricle, right atrium, and the left atrium here. Here we will have our tricuspid valve. This is the mitral valve here. So there is a soft tissue lesion inside the left atrium. We can explain about the image. A soft tissue lesion in the left atrium attached to the interatrial septum. So this is the description which we can give from this image. So next we have to think about which is the commonest soft tissue mass in the atrium, either right atrium or left atrium. Here the options are interatrial septal aneurysm. Next will be left atrial myxoma. Option C is rhabdomyosarcoma and option D is leiomyoma. Here the correct answer will be LA myxoma, left atrial myxoma. So left atrial myxoma will be the correct answer here. Why? What can be the differential diagnosis? The left atrial myxoma or atrial myxoma is the common tumor in the heart. It is the common benign tumor in the heart. Here, a differential diagnosis will be either a atrial thrombus or a myxoma. But here in this image, you can see LA appendage is free. LA, left atrial appendage is free. The most common site of thrombus will be left atrial appendage. The most common site of thrombus in the left atrium will be left atrial appendage. So here the diagnosis will be left atrial myxoma. Investigation of choice will be echo. If you have any other doubt, you can go for MRE heart. Treatment will be always excision with repair. That is called as intracardiac repair. So here we will go with the general anesthesia, and we will go with the cardiopulmonary bypass. Will arrest the heart and will open the left atrium and will enucleate the tumor. And after removing the tumor, the chamber will be de-airing will be done. That is, chamber will be filled with the blood, and slowly cardiopulmonary bypass will be weaned, and the left atrium will, after closing the left atrium. So this will be the management of left atrial myxoma. Next question will be 45 years old patient presented with dyspnea, orthopnea, paroxysmal nocturnal dyspnea. So patient has severe dyspnea. And also on examination, patient had a thoracotomy scar in the left anterolateral aspect. In the consider this to be the thorax, nipple region. Left anterolateral thoracotomy has been performed for this patient. That is 20 years back for same complaints. What will be the likely diagnosis for this patient? So options will be recurrent PDA, mitral restenosis, recurrent CAD, post-CABG. So you should know about the history here. Previously, for a case of mitral stenosis, we are being subjecting the patients to closed mitral commissurotomy. This is CMC, shortly called as CMC. This procedure is usually done through the left anterolateral thoracotomy incision. So from the history, the patient has underwent closed mitral commissurotomy, which is the procedure that is done for mitral stenosis. Okay, so at present, the patient has dyspnea, orthopnea, PND, that is paroxysmal nocturnal dyspnea, and left. What will be the reason for these things? So consider this to be the left atrium, mitral valve, left ventricle. When there is a stenosis of the mitral valve, this will be the pulmonary veins. When there is a stenosis here, the pressure inside the LA, mitral stenosis, pressure in left atrium will increase following the mitral stenosis. This will cause, in turn, will cause, of course, enlargement of left atrium, and also there will be reflection of this pressure in the pulmonary circulation. So patient can develop pulmonary hypertension. Also, patient can also develop significant amount of pulmonary edema. This can be the reason for dyspnea. This can be the reason for dyspnea, orthopnea, and PND in this patient. So here the answer will be mitral restenosis. Why not recurrent PDA? If the PDA recurs, then this is a surgeon's mistake for not doing the surgery properly. Of course, patient can develop coronary artery disease post CABG. Usually CABG is done by midline sternotomy incision for open CABG. In case of totally endoscopic procedures, we can go for a anterolateral thoracotomy also. But 20 years back, I don't think that laparoscopic procedures and minimally invasive procedures has not developed 20 years back. Even the TCAP, total endoscopic coronary artery bypass, is developing only in recent times. So, of course, the post-CMC, the incidence of restenosis will be 40% in 10 years. The incidence of restenosis in post-CMC patient will be 40% in 10 years. So this is a significant number. So this patient is more likely to have mitral restenosis. So next question will be, massive left atrium will be noted in. Here, what will be the answer? Of course, mitral stenosis will also have left atrial enlargement. Even because of aortic regurgitation, there will be a backflow of blood into the left ventricle, and left ventricle pressure will be high, and there will be a left ventricle enlargement too, which can have a increase in back pressure in the left atrium and can also go for left atrial enlargement. And of course, aortic stenosis, there will be a building up of back pressure in the left ventricle, and further there will be an increased pressure in the left atrium too in the long run. And of course, patient can have a left atrial enlargement, but here a massive left atrium will be seen in the mitral regurgitation. So in mitral regurgitation, the massive left atrium will occur because of the increase in the volume overload. There will be a volume overload than the pressure overload. Okay, you have to differentiate between the volume overload and pressure overload. In mitral regurgitation, there will be a volume overload because of the backflow of blood from the left ventricle into the left atrium during the systole. Because of this backflow of blood and increase in the volume overload, this results in the chronic dilatation of the left atrium. This causes massive left atrium. So because of this, what are the complications we can expect? Of course, left atrial contractions will be poor. And because of the stretching of the left atrium, the patient can develop arrhythmias. Commonly, atrial fibrillation and atrial flutter can also occur. In X-ray, the important finding will be splaying of carinal angle, because left atrium will be just located below the carina. When the left atrium enlarges in size, the angle, carinal angle will also increase. This results in the splaying of the carina. So next question, comment on this X-ray and comment on the possible causative factor for this condition. So, of course, we have a session on session at 6 p.m. regarding the X-ray. So here, what is the image you can see? Usually, coming to the right heart, we will have an aortic knuckle first. Aortic knuckle. And then we will have a small hump that marks the main pulmonary artery, followed which we will have a left atrial appendage, and we will have a left ventricle. This is about the left border. But here, we couldn't make out such an aortic knuckle here. Probably here, I suppose. More or less, it is a straight line. All these humps are being obliterated here. In what situation there will be a straightening of left heart border? This is the question here. What will be the condition or causative factor for straightening of the left heart border? Sorry, it's about left heart. This is commonly seen with the severe mitral stenosis because of the enlargement of the, for example, this is the normal thing, aortic knuckle, pulmonary artery, left atrial appendage, and the left ventricle. When this left atrium enlarges in size, this is considered to be the left atrium. This is the left atrial appendage. When the size increases, this will obliterate this area. So at last, it will be like a more or less like a straight line. This straightening of the left heart border is because of the severe mitral stenosis and left atrial enlargement. So we all know about the TAPVC, that is total anomalous pulmonary venous connection or drainage. And it has 4 types: infracardiac, supracardiac, cardiac, and mixed. Also called as intracardiac, which is the least common type of TAPVC here. The least common type of TAPVC will be mixed type. Okay. So coming to the explanation of this question, the supracardiac TAPVC here, the 4 pulmonary veins will drain into the SVC just above the left atrium or above the heart. In infracardiac type of TAPVC, the pulmonary vein will form a vertical vein. It can either drain into the IVC or in the hepatic vein or into the portal vein. This is the infracardiac type of TAPVC. And intracardiac TAPVC, that is intracardiac TAPVC, here the pulmonary vein will drain into the either into the coronary sinus or into the left atrium directly. Left atrium instead of left atrium. So here the pulmonary vein will drain into the coronary sinus and the right atrium instead of left atrium. They will drain into the right atrium directly. So in mixed type, the pulmonary vein can drain at any of these places, either into the SVC or into the coronary sinus or in the right atrium or into the IVC, hepatic vein or portal venous system, portal vein. So this is about the total anomalous pulmonary venous drainage or connection. Coming to the incidence of these different types, supracardiac is the most common. Supracardiac is the most common type of TAPVC. And another important point about supracardiac TAPVC is it will have either a snowman's appearance, or figure of 8 appearance in the chest X-ray. The incidence of infracardiac TAPVC will be 13 to 25%, and intracardiac TAPVC will be 20 to 30%, and a mixed type of TAPVC will be less than 10%. So the least common will be mixed type of TAPVC. So what is the type of dissection depicted in the image? This is also from Bailey and Love. So there are two classifications for aortic dissection, that is DeBakey's classification and Stanford. So what is this here? So the point arrow mark given here will be the point of origin of dissection. Okay. So this is the sinotubular junction, following which we have ascending aorta, arch of aorta, descending thoracic aorta, abdominal aorta. Here there is the bifurcation of abdominal aorta. So here the dissection involves ascending aorta, arch of aorta, descending thoracic aorta, and abdominal aorta. So this comes under the classification of, we'll see about the DeBakey type 1. DeBakey type 1 classification. So based on the site of location of aneurysm or dissection, the classification is being done. In case of DeBakey classification, we have 1, 2, and 3. DeBakey type 1 is, it involves ascending aorta. DeBakey type 1 involves ascending aorta, arch of aorta, descending thoracic aorta. Of course, it can also extend into the abdominal aorta. And DeBakey type 2 means dissection involves only the ascending aorta. It is confined only to the ascending aorta. Does not involve the descending aorta. DeBakey type 3, it involves only the descending thoracic aorta. DeBakey type 3 involves only the descending thoracic aorta, and the lesion does not involve the ascending aorta. And what is Stanford classification? Stanford B. First, we'll start with Stanford B. Involves only descending aorta. Stanford B involves only the descending aorta. Stanford A involves ascending aorta and can extend anywhere. Starting from the ascending aorta, it can either get confined to ascending aorta, or it can involve the arch of aorta and descending thoracic aorta even. This is about the Stanford classification. Of course, the investigation of choice here will be CT aortogram. If the renal parameters are increased, we can go for MR aortogram. Coming to the management part, if patient is fit for surgery, you can go for an open procedure. By this procedure includes resection of the dissected segment and replacing it with the prosthesis. Based on the site involved, the treatment procedure and surgical extent will also vary. If patient is not fit for surgery, we can go for total endovascular procedures also, like TVAR, BVAR even. So the next question, a patient suddenly wakes up at night with the complaints of dyspnea, and anxiety. What is this condition called and what is the cardiac cause for it? Wakes up at night with dyspnea. Simple. It is the paroxysmal nocturnal dyspnea. So what will be the etiology for paroxysmal nocturnal dyspnea? Main thing will be fluid accumulation in the lungs. That is pulmonary edema. Anything that causes pulmonary edema can cause PND. Okay. So what are the options? Paroxysmal nocturnal dyspnea due to left heart failure. Paroxysmal nocturnal dyspnea due to right heart failure. Orthopnea due to left heart. Orthopnea due to right heart failure. So in case of if right heart failure is there, pumping of blood into pulmonary circulation will be impaired. Hope you all get it right. If in case of right heart failure, the pulmonary circulation will be impaired. So because of this, the flow into the pulmonary circulation will be less, and there is a less likely chance for getting a pulmonary edema. So we can do these two options. Of course, this is not an orthopnea. So the answer will be paroxysmal nocturnal dyspnea due to left heart failure. When the left heart failure means left ventricular dysfunction case function cannot pump out the blood free. It cannot pump out the blood on the left ventricle. So what happens here? The afterload will be high. What is afterload? After the heart pumps during the systole, after the pumping, after the end of the systole, the volume left in the heart chamber is called as afterload. What is preload? It is the volume that is present before systole. Okay. So when the afterload is high, the back pressure in the LA will also be high. When there is a high pressure in the LA, this will be reflected into the pulmonary circulation. Patient can develop pulmonary edema. So this is the mechanism behind the paroxysmal nocturnal dyspnea or any dyspnea in left heart failure. What happens in right heart failure? In RV dysfunction, pulmonary circulation will reduce, and of course, afterload in RV will be high. Back pressure in the RA now. So RA pressure will be high, right atrium pressure will be high. So the pressure in the SVC and IVC will also be high. This can result in congestion of liver and other organs. So right heart failure will have congestive liver, pedal edema, third space loss like ascites. Okay, so this is about the right ventricular failure or right heart failure. The next question, what is the pathophysiology behind the aortic regurgitation in the VSD? So, you should know about the image here. This is the aorta. This is the pulmonary artery. This is the VSD, ventricular septal defect here. because of the Venturi effect. Patients with VSD will have aortic regurgitation. Patient with VSD will develop aortic regurgitation because of the Venturi effect. How this happens? You can see the image A. There will be the flow of blood from the left ventricle to the right ventricle during the systole. And also there will be flow of blood into the aorta during the systole. And here in diastole, there will be backflow of blood here. And this will be, here we have an intact compactable aortic valve. When the time goes, when there is the flow of blood from the left to right, you can see here the aortic valve cusp is also being pulled during the systole. When the blood, this is the aortic valve, open aortic valve. This is the VSD. This is the interventricular septum, and this is the subaortic VSD. During systole, from the left ventricle, blood flows into the aorta and also through the VSD into the right ventricle. While passing through the VSD, this current will also, this current of flow, this flow current will also pull the leaflet or cusp of the aorta also. This results in the malformation of aortic cusp in a long run. So this malformed cusp, you can see this, it is not a normal thing. Here it is being pulled into the right ventricle because of the passage of blood into the right ventricle. Because of this, there will be a faulty coarctation. Because of this deformation of the aortic cusp. So this is why, this is how the VSD patients can develop aortic regurgitation in a long run. Okay. So the answer will be Venturi effect. Coming to the Pulsus paradoxus seen in, where it is seen. Thus, what is Pulsus paradox? So during the normal inspiration and expiration, the arterial pressure will vary. This is the diagram of Pulsus paradox. During inspiration and expiration, the pulses will, the arterial pressure, systolic pressure will vary. There will be a fall in pressure during inspiration because of the compression of the heart by the lungs. Okay, so this is the Pulsus paradoxus, and this will be a very normal phenomenon if the fallen BP is less than 10 millimeter of mercury. This will be considered to be a normal phenomenon. When this fallen BP is more than 10 millimeter of mercury, this is considered to be a pathological and Pulsus paradoxus. Okay. So where it is being seen, this Pulsus paradoxus can be seen in the pericardial tamponade. This Pulsus paradoxus is seen in pericardial tamponade. So nothing but it is an exaggerated drop in the systolic blood pressure during inspiration exceeding more than 10 millimeter of mercury. This is seen in conditions like cardiac tamponade, severe asthma, and COPD. There will be hyperinflation of the lung and causing compression of the heart. This results in the reduction of the systolic blood pressure. And of course, there will be constrictive pericarditis and pulmonary embolism can also cause Pulsus paradoxus. So it's clear, right? If the variation in the systolic blood pressure during inspiration and expiration is less than 10 millimeter of mercury, then it is considered to be a normal phenomenon. If it is more than 10 millimeter of mercury, it is considered to be pathological Pulsus paradoxus. So, 13th question. A child presents with a tachypnea, easy fatigability with cyanosis of lower limb. What is your probable diagnosis? So, cyanosis can be of several types. Central cyanosis, peripheral cyanosis, of course, differential cyanosis. So, we will go with the options here. First is the coarctation of aorta with PDA. Second will be congenitally corrected transposition of great arteries. Third will be supracardiac TAPVC. And option D will be AV canal defect. Maybe an ASD with VSD with malformed valve abnormalities even. Here, patient will be tachypneic and easy fatigability. Easy fatigability means there is no proper energy for the muscles to be active enough. There is no proper lung perfusion here. And patient has cyanosis only in the lower limb. There will be cyanosis in the lower limb. So this is the coarctation of aorta here. There are types of coarctation, depends on the severity. Okay, we should know about the grading and the categorizing of the coarctation of aorta even. When there is a coarctation here, consider this to be the ascending aorta, arch of aorta having a left subclavian, left common carotid, and the right brachiocephalic trunk. The upper limb will receive normal flow of blood. Here you can have the main pulmonary trunk. And there will be a PDA here. PDA here. There will be a luminal narrowing in the coarctation of aorta. So in this situation, the upper limbs will receive the normal oxygenated blood, whereas as there is a luminal narrowing here and a PDA opening here, there will be a flow of deoxygenated blood into the lower limb, resulting in the lower limb cyanosis even. So from this scenario, we can go for coarctation of aorta with a PDA. And of course, here you can make it clear. Aorta from the left ventricle carrying the oxygenated blood into the ascending aorta, descending aorta. And before reaching descending aorta, in arch of aorta, it gives supply to the left upper limb through the subclavian and the head and neck through the carotids, to the right through the right subclavian. And in the descending thoracic aorta, there is a luminal narrowing caused by coarctation of aorta. So the flow to the descending thoracic aorta and the rest of the body will be affected. And when there is the persistent ductus, that is a patent ductus arteriosus, there is a flow of deoxygenated blood from pulmonary artery through PDA into descending thoracic aorta, then into abdomen aorta, then to the lower limbs and other parts of the organs. So this is the reason behind the distal cyanosis. This was an image from the Bailey. What is this valve? This name is valve. This is the left side of the heart. And this is the right side of the heart. You have a bicuspid valve here. That is a mitral here. And tricuspid here. We have two things here. Anteriorly and posteriorly. What is being located? Anteriorly and posteriorly, what valves are being located? So, more anteriorly, we will have our pulmonary valve from right ventricle. That is from pulmonary artery, in pulmonary artery. And then we will have an aorta. Both are tricuspid valves. So here the answer will be aortic valve. An aortic valve is a tricuspid valve. It has a three cusp. There is right cusp, left cusp, and non-coronary cusp. Right coronary artery arises from the right cusp. Left coronary artery arises from the left cusp. Next question. Read the X-ray image and comment on the findings. Which of the following will be correct from the four options? This is the X-ray chest PA view with an implanted pacemaker here, sending two pacing wires. You can see you can differentiate the two wires here. One will be here. You can see this is the RA. This will be the SVC here. This will be the aorta. This is the pulmonary bay. And here we can have a small left atrial appendage followed by a left ventricle. And here we will have a this is RV, LV, RA, aorta, pulmonary artery, left atrial appendage, SVC, AVC. We will incorporate this thing. So we have leads opening into the RA and the ventricle. You can see you have a lead, one lead is here, another will be here. So here this the answer is this is the considered to be a biventricular pacing. Though it is in the atrium, this will be used for pacing the right ventricle because of the conduction system. What is LVAD? What is BIVAD? LVAD is nothing but it is a left ventricular assisting device. If this is the left ventricle, from left ventricle to the aorta, this will be the mitral valve, aortic valve. We will have a device placed at the apex of the left ventricle. This will take out the blood from here and will push it into the aorta. This is the LVAD, left ventricular assisting device. When both the ventricle are being supported, this is called as biventricular assisting device. So the image here given in this X-ray is the biventricular pacer. So you know a bit about the pacer too. Types of pacer based on the duration. Either it can be a permanent pacemaker or a temporary pacemaker. Like commonly we use a temporary pacemaker in post cardiac surgery patients. We will go with an epicardial pacing. We'll go with an epicardial pacing. Permanent pacemaker for patients with heart blocks. Patient with arrhythmia and heart block may need a permanent pacemaker. And based on the pacing, it can either be a single chamber, either a right atrium or right ventricle, or a dual chamber pacemaker pacing the right atrium and the right ventricle as given in this X-ray. And the biventricular pacer Biventricular pacer will pace the right atrium, right ventricle, and the left ventricle. So this is how the pacemaker is being introduced. So again an image-based question. So mention the findings in the fluoroscopy image and the condition for which this procedure is done. First, find what is the finding in this fluoroscopy, and what is the indication for this procedure. Here you can see a narrowing here. You can consider this to be the edge of aorta, listening thoracic aorta, with a narrowing here. Most likely to be a coarctation of aorta. Here you can see something like a mesh. A guide wire is being inside now, and a stent-like thing is being placed here to maintain the patency and to enlarge the lumen here. So can be considered to be an aortic stenting. Or total endovascular aortic repair or replacement even. This procedure called as TEVAR, total endovascular aortic repair or replacement, can be done for aortic dissection, aortic aneurysm, and coarctation of aorta even. So the answer will be all of the above. TEVAR is a minimally invasive procedure. It is a minimally invasive procedure. It is gaining more importance in the aortic dissection and aneurysm because of its less morbidity. Of course, mortality is also very less in TEVAR, but long-term outputs of TEVAR are yet to be studied. So the next question will be left atrial enlargement with left ventricular hypertrophy and an ST depression changes are seen in which of the following condition? Pulmonary stenosis, something related to the right heart, right atrium, right ventricle, and tricuspid valve. So this can be ruled out. ASD, VSD with the aortic stenosis. These are all three options which we have. VSD is something related to the ventricles. So left atrial enlargement is unlikely here in VSD. So we are ruling out this also. In ASD, always there will be a flow from left to right. Only in case of Eisenmenger-Wengerization or in Eisenmenger syndrome, there will be a reversal of flow. So there won't be any pressure overload or volume overload in the left atrium. In fact, the pressure will reduce and volume will reduce because of the shunting of blood from the left atrium to the right atrium. So this is also not the answer here. So the answer will be aortic stenosis. Because of the aortic stenosis, the left ventricle should pump the blood with a high pressure and the contraction should be more powerful against the stenotic area. So there will be hypertrophy. There will be hypertrophy of the left ventricle. There will be hypertrophy of the left ventricle. Okay. And also, because of this, the afterload, because of the stenotic area, the afterload will be more in the left ventricle. This causes increased back pressure in the left atrium. There will be an increased back pressure in the left atrium. So here in the left atrium, the preload will be high, resulting in the left atrial enlargement. Okay, so the first two things have been explained with aortic stenosis. Why ST depression, ST segment or ST depression? When the musculature of the ventricle increases, the duration of travel of the impulse to reach the far end point for contraction will also increase. This results in the increased duration of the transmission of impulse, resulting in ST depression. So here the answer will be aortic stenosis. In aortic stenosis, as the left ventricle have to contract against the stenotic valve, this results in the left ventricular hypertrophy, and because of the increased pressure, left atrium also enlarges. In ECG, as the electrical impulse have to travel through the hypertrophied muscle fibers, the time taken and the energy impulse needed is also more, resulting in the ST depression and T wave inversion. Coming to the thorax, right now, a 60 years male patient who is a smoker has been presented with the OPD with hemoptysis. So next, following hemoptysis, to find the source for hemoptysis, we are going with the bronchoscope. So we get this kind of finding. What is this? This is also from Bailey and Love. We can see the tracheal rings here. Tracheal rings are U-shaped, incomplete rings. Tracheal rings are incomplete rings. You can see here, it starts from here, it goes in this area and here. Beyond this area, until this area, we couldn't see any rings. So it is an incomplete ring. And in the trachea, we can see a proliferatory mass in the bronchus. You can see the proliferative mass in the bronchus, which may be the source of bleeding. So the answer will be a bronchial tumor. So the texture and the nature of the mass in the bronchoscopy is suggestive of bronchial tumor. And this neoplasm, always any neoplasm, has a high chance of bleeding because of the increased vasculature, and this can result in hemoptysis. And of course, aspergilloma can also cause hemoptysis, but this aspergilloma can occur in the lung parenchyma, especially in the lung that contains a cavitary lesion. So you can rule out aspergilloma in mucous plug. The answer will be bronchial tumor. And of course, endobronchial biopsy, and we should also know about EBUS, endobronchial ultrasound. This is used to find the extent of the tumor, and the layers of the bronchus or trachea that is being involved. Okay. Next will be a 19th question. A 55 years old chronic smoker presented with an enlarged painful toes and fingers with a swollen joints, and also patient had dyspnea and hemoptysis. Patient has a dyspnea and hemoptysis. X-ray of the limbs shows elevated periosteum, and of course X-ray chest shows heterogeneous opacity or a ground glass opacity. What will be the probable diagnosis here? So this is picture of paraneoplastic syndrome? This is a feature of paraneoplastic syndrome. The answer here will be hypertrophic pulmonary osteoarthropathy or the hypertrophic pulmonary osteoarthropathy. So what is hypertrophic pulmonary osteoarthropathy? It is a triad including clubbing, periosteitis, and a painful arthropathy. It is usually associated with the CA lung, and of course, this can also occur in other pulmonary conditions also, like chronic bronchitis, bronchiectasis, pulmonary fibrosis, pneumoconiosis, that is work spot related injuries or the work spot related infections like silicosis and pleural mesothelioma. This also can cause, all these things can cause hypertrophic pulmonary osteoarthropathy. In lung cancer, the most common variant that can cause hypertrophic pulmonary osteoarthropathy is non-small cell lung cancer. Non-small cell lung cancer. So what is the pathophysiology? What is the pathophysiology behind? It is the paraneoplastic syndrome. It is a paraneoplastic syndrome. There is a release of growth factors. There will be the release of growth factors and increase in the circulation to the distal peripheries. There will be release of growth factors. This causes excessive collagen deposition and endothelial hyperplasia, also new bone formation. Because of the release of growth factors, there will be a excessive collagen deposition, endothelial hyperplasia, and new bone formation. This is the pathophysiology behind the hypertrophic pulmonary osteoarthropathy. How will you manage this condition of hypertrophic pulmonary osteoarthropathy? Of course, symptomatic management like analgesics, anti-inflammatory, etc., and have to deal with the underlying cause. In case of lung carcinoma, we have to deal with the surgical resection of lung carcinoma or a chemotherapy or radiotherapy. Or in case of bronchitis, should go with the medical management to alleviate the bronchitis, and only then the HPOA will be cured. Next question. A 15 years old male patient was operated for chest wall deformity. A 15 years old male patient was operated for chest wall deformity, and his post-op, this is the post-op X-ray shown here. There's a long bar being placed in the subcutaneous plane or just below the subcutaneous plane here. So what is the procedure done here and what is its indication here? So of course, from this scenario, it is a procedure that is done to correct the chest wall deformity. So this bar is called as Nuss bar. The procedure is called as Nuss procedure. And this is done for pectus excavatum. So, what are the answers here? Giovanni procedure for pectus carinatum, Morgagni procedure for preventing diaphragmatic hernia, and Nuss procedure for correcting the pectus excavatum. So the correct answer will be Nuss procedure for correcting the pectus excavatum. So how it is being done? A metal bar, this is called as Nuss bar, is placed behind the sternum to hold the sternum in its new position. It will be like an excavated area here, like this. So we will push it up, and we'll bring it to this kind of alignment, and the bar will be placed here so that this does not go back. The corrected sternum will not go back into the old position. And this bar can be removed after a period of time. And this can be done through a thoracoscopic guidance even. So it is not a open surgery. It can be done through the thoracoscopic guidance also. So next question will be Losses flap, where it is done and for what it is being done. Bailey has a wonderful image for Losses flap. Even that image can be asked as a question in the forthcoming exams. So what is Losses flap? It is the window thoracostomy. It is also called as window thoracostomy. Here, we will create a permanent opening in the chest wall to drain the fluid from the pleural space. Losses flap is a permanent procedure. So make it clear that it is a permanent procedure where an opening is created in the chest wall to drain the fluid from the pleural space. This is commonly used for chronic empyema due to tuberculosis. And it will be done at the posterolateral region of the chest wall. This Losses flap is being done at the posterolateral region of the chest wall. Of course, it is a permanent thing and it is not a reversible procedure. Now we have a modified Losses flap where the opening will be covered by the skin even, with a skin flap. So this is about the Losses flap. So the answer will be the Losses flap is done for chronic empyema. It is a permanent one. It is a permanent opening created in the chest wall for draining the fluid or pus from the pleural space. The common site of Losses flap will be posterolateral aspect. Indications will be chronic empyema, that is pus in the pleural space. And of course, it is not reversible. This can also be asked as a question, and any points you have to remember. It is also called as window thoracostomy. Here you can see a small opening is made in the posterolateral aspect. Even the ribs are being cut down, and the skin flap will be raised. Here, here the opening will be made, and it is being sutured here. This is the Losses flap. Here we have a skin flap here to cover the area. This is the modified Losses flap. The skin flap will be used to cover the opening here in the modified Losses flap. Next question. A 34 years old female with a history of PTB followed by destroyed lung underwent a right pneumonectomy. So patient is a case of post-pneumonectomy. Okay. A follow-up X-ray was taken for the patient. And the X-ray is being given here. You can see so here we have a case of destroyed lung who underwent a right pneumonectomy. Following the surgery, a post-op X-ray is being taken, and the X-ray shows air fluid level. Means we can consider it to be a hydropneumothorax. So which of the following statement is true? So coming to the options, patient has a hydropneumothorax, which is a normal natural course following the pneumonectomy. Option A. Option B, hydropneumothorax due to bronchopleural fistula. Option C, infection resulting in pneumothorax. Which of the following can be the correct option or correct answer? Option A, I will repeat, is a hydropneumothorax following a normal natural course of pneumonectomy, or hydropneumothorax due to bronchopleural fistula, that is BPF. And option C is infection resulting in pneumothorax. So there is no words about fever or pain in this question. So we are ruling out it to be a pneumothorax. So option C is being ruled out. Either option A or B. The most common thing here is option A, because in the natural course of pneumonectomy, following pneumonectomy, patient will have air fluid level. Patient will have air fluid level, and this air fluid level, this air will be slowly absorbed, and this will be filled with the fluid, which will get opacified later. So the answer will be hydropneumothorax, which is a normal natural course following the pneumonectomy. So this X-ray following a pneumonectomy is a normal thing. Okay. After pneumonectomy, chest X-ray should be taken, and this chest X-ray will show an air fluid level, because in the post-surgical space, that is in the post-surgical dead space, fluid accumulates over the time, and the rate of accumulation of fluid in the dead space will be 1 or 2 intercostal spaces per day. And rate of accumulation of fluid will also be high, approximately 1 or 2 intercostal spaces a day. Okay, so there are stages of filling of this dead space. In initial phase, initially in the post-surgical space, there will be filling by air. Air will be filled in the pleural cavity, followed by fluid accumulation. Followed by fluid accumulation. This usually starts accumulating in the pleural space, replacing the air, and the rate of filling will be 1 or 2 intercostal spaces per day. And then the air in the pleural space will be gradually replaced by fluid, and this results in the opacification of the hemithorax. So this is the stages of a natural course following the pneumonectomy. So initially, after pneumonectomy, the dead space will be filled with air, and this air will be slowly reabsorbed and replaced by the fluid. This fluid will get accumulated at the rate of 1 or 2 intercostal spaces per day, and this air in the pleural space get replaced with the fluid, and this fluid will get opacified, and this will fill the dead space here. So coming to the next question, a 45 years old male was admitted with history of fever, dyspnea, and patient had a previous history of trauma, followed by a right hemothorax, which is managed conservatively. So a 45 years old male with a history of fever and dyspnea, he had a previous history of trauma in which he suffered from right hemothorax, which was managed conservatively. So patient is also a known case of type 2 diabetes. Patient is also a known case of type 2 diabetes, and his recent chest X-ray is being given here. So next session on around 6 to 8 will be, 7 to 9 will be a session on X-ray. So I'm not going deep into the X-ray, just going for the findings in this X-ray. You can see a homogeneous or lockulated collection here. Lockulated collection here. So patient has fever, and dyspnea may be suggestive of an infective etiology. Patient is a known case of type 2 DM, might be a immunocompromised and high risk of infection is there for this patient if he is not under adequate glycemic control. And patient had a right hemothorax, that is blood in the pleural cavity, which was managed conservatively. Here. So of course, all know that blood is a good culture medium. This hemothorax might have got infected and results in pyothorax or empyema. So from this history and this image, we can conclude this diagnosis as empyema with a thickened pleura. Can make it clear again here. The pleura here is being thickened. You can see a thickened layered lining here. So because of this, we can answer it as empyema with thickened pleura. So next question, a 65-year-old male, known case of type 2 DM with a poor glycemic control. And of course a chronic smoker, was admitted with a history of fever, even breathe. Patient has a foul smelling during breath, that is halitosis. Patient has halitosis, subjected to a chest X-ray, which shows a cavitatory lesion with the air fluid level. So how to describe this lesion in the X-ray? It is a cavitatory lesion with the air fluid level. So cavitatory lesion with air fluid level. And of course, patient has a poor glycemic control. Patient has more chance of getting infection. Fever is also a sign of any inflammation or infection. And a foul smelling cough, halitosis. Then this image is suggestive of lung abscess, cavitatory lesion with the air fluid level is suggestive of lung abscess. Okay. So, of course, as a patient is known case of type 2 diabetes and with a poor glycemic control, patient might have got any immunocompromised or poor immunity. So he might have developed lung abscess. So next question, a 42-year-old male with old PTB. Of course, patient has completed anti-tubercular therapy. Now again presents with hemoptysis. And the X-ray done here shows a cavitatory lesion. With a crescent of air. You can see air shadows here and there. Cavitatory lesion with a homogeneous opacity inside the cavity. With the crescent of air around the homogeneous lesion. So here you can see a cavity with the mass here. And of course, here and there is an air. Okay, so this homogeneous opacity can be a fungal ball. this cavitatory opacity can be a fungal ball. So cavitatory lesion containing a fungal ball with a crescent of VR around the soft tissue lesion. So the answer here will be aspergilloma. A sign will be Monod's sign, or you can say call it as a crescent sign. Answer will be a Monod sign or a crescent sign. So what is Monod sinus? It is a gas around the mobile fungal mass or a mycetoma in a pre-existing pulmonary cavity. In a pre-existing pulmonary cavity. This is the Monod sign, crescent sign, a crescent-shaped gas shadow between the fungal ball and the cavitary tissue. These both are commonly seen with aspergilloma of lung. Coming to the 26th question. Name the condition. An easy question. Name the condition where there is an absence of pectoralis major, pectoralis minor, and the syndactyl. The answer will be Poland syndrome. So, what is Poland syndrome is? It is a rare congenital condition that affects the development of the chest wall. It affects the development of the chest wall and the upper limb on one side of the body. So, Poland syndrome will affect the development of the chest wall and the upper limb on the one side of the body. It is characterized by either the absence of pectoralis major muscle, and sometimes even the pectoralis minor will also be absent. So, in sometimes pectoralis minor will also be absent, and patient can also have syndactyl. So, the other abnormalities associated with Poland syndrome are underdeveloped breast tissue. So, there will be an underdeveloped breast tissue, rib abnormalities, and shortening of the forearm bones. Shortening of the forearm bones, like ulnar radius shortening, will be there. And of course, patient can have a spine deformity or kidney abnormalities. Developmental anomalies of kidney can also be seen in the Poland syndrome. So Poland syndrome is a rare congenital condition that affects the development of the chest wall and the upper limb on the one side of the body. And it is characterized by absence of pectoralis major muscle, and sometimes even the pectoralis minor can also be absent. And also it is associated with syndactyl, and sometimes that can be underdeveloped breast tissue. And of course, rib abnormalities can be present, and shortening of the ulnar and the radius bone can be seen. And of course, spine deformity with kidney anomalies can also be present. So coming to the next question, 27th question about thoracic outlet syndrome. The thoracic outlet syndrome, here the Roos test is positive. So we are concluding this as a neurogenic thoracic outlet syndrome. Of course, we have a neurogenic arterial and venous thoracic outlet syndrome based on the structure that is being compressed and creating symptoms. Which of the following statement is correct regarding the thoracic outlet syndrome? Preferably neurogenic thoracic outlet syndrome. All patient may need, option A, all patient may need 4 to 6 weeks physiotherapy before and consideration of surgery. Option B, neurogenic thoracic outlet syndrome is common than the venous and arterial thoracic outlet syndrome. Option C, thoracic outlet syndrome is common in women than men. So here, all the above statement are correct. So you will see about the thoracic outlet syndrome. This thoracic outlet syndrome is an important topic. We will get a question from this always. So here, there is nothing but either the nerve, vein, or artery will get compressed in the thoracic outlet. So based on a structure which is being compressed, the symptoms will be present. If the nerve is being compressed, then the patient may have pain, numbness, like a pain, numbness, tingling sensation, and weakness in the arm and hand. When artery is being compressed, patient can have pain and coldness. Periphery will be cold, and there can be discoloration of the arm and the hand. When the veins are being compressed in the thoracic outlet, then it results in swelling of the hand, followed by pain and discoloration. So this is about the thoracic outlet syndrome. Coming to the management aspect, of course, radiological imaging is done, followed by electrophysiological studies are done, like nerve conduction study and about muscle contraction studies are being done in case of neural or nerve involved thoracic outlet syndrome, followed by physiotherapy initially to relieve the compression, followed by medical management with analgesics, anti-inflammatory, and steroids. If not cured by this thing, then we should go for surgical decompression. Surgical decompression is just a last stage of management. 28th question. A 50 years old male patient presented in OPD with dyspnea, easy fatigability, and drowsiness. So patient had dyspnea, easy fatigability, and drowsiness, and he is a known case of CA lung. He is a known case of CA lung. On that investigation, patient had serum sodium as 128 milliequivalent per liter. That is a hyponatremia is seen. So what will be the diagnosis here? Patient has a small cell lung cancer, or a large cell lung cancer, or an adenocarcinoma of lung, or a non-small cell lung cancer. Before that, what was the diagnosis for the above condition? There is a loss of sodium, or there is a dilution of serum. If sodium have to be reduced in blood, then you have two options. Either sodium is being excreted, or sodium containing fluid will be diluted. Okay. So here, we should all know about the SIADH, syndrome of inappropriate antidiuretic hormone. Okay. So this hyponatremia in lung cancer is commonly due to the SIADH. This is more common with small cell cancer of lung. This is more common with small cell lung cancer. So the incidence of SIADH in patients with small cell lung cancer is 15%. The incidence of SIADH, that is syndrome of inappropriate antidiuretic hormone secretion in patients with small cell lung cancer is 15%. And this comes under paraneoplastic syndrome of small cell lung cancer. This SAADH comes under banner of paraneoplastic syndrome associated with small cell lung cancer. Here, it is characterized by inappropriate release of ADH. There will be an inappropriate release of ADH, resulting in increased water retention and hyponatremia. So there will be dilution of the blood, resulting in hyponatremia. Here we should manage this patient with fluid restriction and preferably tolvaptan. Then, of course, loop diuretics like furosemide and hypertonic saline can also be used. This is about SAADH. It is a paraneoplastic syndrome. Associated with small cell lung cancer, and its incidence in small cell lung cancer is 15%. Here there is an inappropriate secretion of antidiuretic hormone resulting in fluid retention. Water retention in the body occurs, resulting in dilutional hyponatremia. This can be called as dilutional hyponatremia. This can be managed by giving fluid restriction and tolvaptan, and of course hypertonic saline to increase the sodium level, and loop diuretic for increasing the excretion of the fluid. Okay, next is the 29th question here. A 35 years old male had an RTA, following which the patient had a chest trauma with the absent breathing sounds or absent breath sounds in the right side. And of course, the trachea is shifted to the opposite side. Here you can see it in this image. Trachea is being shifted towards the opposite side. What is the diagnosis? Here I have marked with make them some marks, but the exam we won't get any markings like this. Okay, for copyright purpose from the exam, I have marked here, and there will be no markings in the exams. So from this image, what you can conclude? Of course, the air will be black in color because it is the least dense thing here. The air is black. What is the difference between this area and this area? We can see bronchovascular markings till here. Till this area, we can see the bronchovascular markings. Behind this area, there is no bronchovascular markings. This is to differentiate between the pneumothorax and normal lung area. Okay, so this is a case of pneumothorax. In pneumothorax, the mediastinal push will be there in case of massive pneumothorax. That is the reason for tracheal shifting. That is the reason for tracheal shifting. So the answer will be pneumothorax. Why not hemothorax? Hemothorax, as the fluid will get accumulated in the lower region, dependent position, the cardiophrenic angle and the costophrenic angle are normal and is not blunted out. So it is not a case of hemothorax. In case of cardiac tamponade, you will have a cardiomegaly with a narrow pedicle. And of course, clinically, we will have a Beck's triad. We should also know about the Beck's triad here. Beck's triad can also be asked individually. Hypotension, engorged neck veins, and third is the muffled heart sounds. So this is the Beck's triad, which you are supposed to know. So it is not a case of cardiac tamponade. And coming to subcutaneous emphysema, we couldn't see any subcutaneous emphysema in the soft tissue areas. So this is also wrong. So the answer will be pneumothorax. What is pneumothorax is? It is nothing but it is an air in the pleural cavity. Between the, where does the pleural cavity lies? Pleural cavity is nothing but it is the space between the parietal and the visceral pleura. So accumulation of air in this pleural cavity can cause collapse of the lung. And this can also cause tracheal shifting to the opposite side also. So coming to the 30th question, a 30 years male patient was brought to emergency room with a history of penetrating chest injury. On examination, we have an open laceration of around 4 cross 1 centimeter with pleural cavity deep. So on insulating the finger with after administrating local anesthesia, we can feel the lung even. The patient had a silent chest on the same side. What will be the diagnosis? Very simple. It's an open pneumothorax. That will be answer here. And how to manage this open pneumothorax? How to manage this open pneumothorax? First will be applying a three-way plaster. We will apply, if this is the opening here, we will apply a three-way plaster here without occluding the one side of the plaster, one side of the dressing, so that during inspiration, the plaster over the wound will get attached or will not allow the air to enter into the pleural cavity. It will act as a one-way valve. During inspiration, this is considered to be an opening here. This is the open injury. If there is a plaster here, during inspiration, there will be sucking force here into the cavity because of the negative pressure inside the thorax. The plaster will get attached to the chest wall and will not allow the air to enter. Similarly, during expiration, the force inside the lung thoracic cavity will be more. This will push the air because of the positive pressure that will be pushing of air will be there. So the plaster will give way and the one unplastered area, so the air will come out. So this three-way plaster dressing will act as one-way valve. And of course, following this, we should go with an ICD insertion to remove the trapped air inside. Okay, so this is about the 30th question. Next will be penetrating chest injury following a gunshot. And there is an enlarged distended neck veins here. There is an enlarged distended neck veins. And there is a decreased breath sounds. There is a tracheal shifting too. What is the probable diagnosis here? Yeah, you should go with the enlarged neck veins, as we have seen before. In case of Beck's triad, enlarged neck veins can be due to compression of the heart. Okay, this compression can be due to anything like a pneumothorax or a hemothorax. Okay, so here in tension pneumothorax, leave about the Beck's triad. In tension pneumothorax, the neck veins will get distended because of the increased thoracic pressure. So it is a clinical diagnosis. Make sure that tension pneumothorax is a clinical diagnosis, and we need not wait for a radiological image. We need not wait for a radiological imaging. We should go for an ICD insertion directly as an emergency procedure to save the life of the patient. So here the answer will be emergency tube thoracostomy. This will be the first step for penetrating chest injury with distended neck veins, decreased breath sounds, and trachea shifted to opposite side. This is the answer for 31st question here. Here you can see there is a massive pneumothorax. Massive pneumothorax. So clinical diagnosis can be tension pneumothorax. Should be managed by emergency intercostal drainage tube insertion. This tube thoracostomy should be done here. So here the answer will be tension pneumothorax. So this is about the open pneumothorax here. Next, the second question. A 29 years old male presented to emergency room following an RTA. Patient had a massive hemothorax and the ICD insertion was done. Patient had a massive hemothorax, that is blood in pleural cavity. ICD insertion was done. What will be the indication for thoracotomy? What is the indication for surgical open thoracotomy or a VATS-guided thoracotomy? What will be the indication here? So this is the image where we can see left side, there is a collection here. This can be considered as an Ellis curve. We should all know about the Ellis curve. This is an X-ray finding of left moderate pneumothorax. Moderate, okay? Moderate pneumothorax here. There is a blunting of costophrenic angle. Of course, cardiophrenic angle is also not seen here. So this is a case of hemothorax. So what is the indication for? What are the indications for thoracotomy? So option A will be 1500 ml of initial output following an ICD insertion. So immediately after inserting an ICD, if the drain is 1500 ml. So this is the first option. Option 2 is 150 ml per hour for 2 to 4 hours. Or more than 200 ml per hour for 3 consecutive hours. Option D, patient who requires multiple transfusion of blood products. Multiple transfusion of blood products for maintaining the hemodynamic stability. So the answer here will be all of the above. If a patient is diagnosed to have a hemothorax following an ICD insertion, immediately after an ICD insertion, if you are getting a drain of 1500 ml, then it is an indication for thoracotomy and to find the source of bleeding and to arrest the source of bleeding by open procedure or VATS, video assisted thoracoscopic surgery. Or if the patient or the ICD drainage is 150 ml per hour for 2 to 4 hours continuously, then we should go for open thoracotomy. And if the drainage is more than 200 ml per hour for 3 consecutive hours, we are supposed to go for open thoracotomy. And also, sometimes there can be an occult hemorrhage. Hemorrhage can be inside the thoracic cavity. Sometimes ICD tube can be clotted, or the clot can be obstructing the ICD tube, that is tube thoracostomy. Then the drain will be less. But the patient may need multiple transfusion to maintain the hemodynamic stability. So in all these conditions, we are supposed to go for thoracotomy and to find the source of bleeding and to surgically correct the source of bleeding. So next question is the last 33rd question. A 55 years old female patient, a known case of status post mitral valve replacement. Status post mitral valve replacement. Patient is on warfarin, an anticoagulant. Now the patient has been diagnosed to have an acute appendicitis, planned for an appendicectomy, either open or a lap. What to be done before surgery? Because patient is on anticoagulant. Okay, so will you transfuse either a cryoprecipitate or a platelet or FFP or none of this? Patient is on warfarin, which is an anticoagulant. So we are in need of clotting factors right now. So I would go with FFP transfusion. If in option, fresh whole blood is being given, we can go with fresh whole blood transfusion even. All valve replacement patients, we will go with an anticoagulant and maintain the INR at the higher level of 2.5 to 4.5. As per institution norms, it can vary from 2.5 to 4.5. So these patients, when subjecting to any surgery, we will stop the anticoagulant and will neutralize the anticoagulant effort or effect. Then we will bridge the time with heparin, because heparin has a short half-life of 6 hours. So if the patient is on heparin, the anticoagulation will also be maintained. And also, we can stop the heparin just 6 hours prior to surgery. And of course, can start it 6 hours after the surgery if the surgeon is very confident about hemostasis. So an answer will be FFP. Of course, warfarin is an anticoagulant. This will affect the clotting time. This will affect the clotting factors, results in the increased clotting time and INR. In case of emergency surgery, elective surgery, we can withhold the warfarin and monitor the INR and wait until the INR becomes normal. That is, international normalized ratio becomes normal. And we can start with heparin as a bridging therapy. But in case of emergency, if you are going to operate at the earliest time possible, we will go with FOP transfusion and vitamin K injection, which contains clotting factors. And of course, a fresh whole blood transfusion can also be planned. And heparin is being used as a bridging therapy because it has a short half-life of 6 hours. So this is about the NEET Super Specialty 2025. Of course, it is an easy task. You all can rock this exam with a proper systematic preparation. So all the best, guys. Hopefully, everybody will get a seat at this time itself or even in the next attempt. If any doubt, they can approach me at any time regarding cardiovascular and thoracic surgery. So thank you. Shall we complete it? No questions in the message box? So we will end this talk. Thank you. Next, we will be meeting at with an X-ray discussion by 7 o'clock in 1 hour.